Afternoon, everyone. Thanks for joining us. We're going to give it a couple minutes to fill the room here. Room seems to be filling up quick here, so we'll just give it another minute here. And we'll give it about 30 more seconds to get started. Well, good afternoon, everyone. Thank you once again for joining us for our weekly Wednesday webinar series. Today's webinar is on the State of the Science update and what to expect. This is part one of a two-part series. My name is Brett Patel. I'm Vice President here at the National Hemophilia Foundation. At any point during the webinar, if you would like to ask a question, please use the Q&A feature at the bottom of your screen. We have NHF staff members monitoring these questions, which we will pose to our presenters after the presentation. This webinar is being recorded and will be available to the community beginning on Friday, August 6th. I'm joined today by our State of the Science Working Group chairs, so I asked them to introduce themselves as they come up with their presentation. But to get us started, we're going to start with Dr. Maggie Ragni. And Maggie, if you'd like to share your screen, the floor is yours.
All righty, thank you. Let me see if I can get these up here. So good afternoon. My name is Margaret Ragni, and I was the chair of Working Group 6, subcommittee known as the Resources and Funding subgroup. So the charge to our working group was to facilitate IBD research and bring the community stakeholders together to establish a national blueprint for IBD research, addressing three main areas: registries and observational studies. And you can see that includes various different post-licensure therapies, data collection, relevant patient-centered outcomes, clinical trials, and we were really interested in novel approaches to small trial design, decentralized methods, how to do feasible trials in this community, and finally, funding, how to sustain this very critical approach in research and how to optimize our private and public partnerships. So this was a daunting task, and I knew I didn't have all the answers. So what we did in our subgroup was to invite speakers every week to talk about what we thought were the most critical areas: data collection. And you can see we talked about machine learning, big data, models for data collection, healthcare and prediction models, various different data collection database and approaches. We also talked about clinical trials and heard a lot about platform trials, trials for rare diseases, how to embed trials within the HTC, and decentralized trials. We also talked about community partnerships and how critical the community is in this whole endeavor. They need to be involved from beginning of concept design all the way out to participation. We understood a lot more about community partnerships, and we learned a little bit about the Community Voices for Research, CVR. And finally, in terms of funding, what will it take to sustain this? We heard strategies that enhance industry partnerships, how NHF is overseeing and promoting the research initiative. And we also talked with our funding partners at FWGBD and HTRS to see how they made this happen. But taking all this together, we came up with an envisioned organization in which we could conduct research that, if you look at the bottom here, that could be actually sustained and supported by the Community Lifespan Registry, and that utilizes EMR, which of course is the electronic medical record, and big data or machine learning to enable observational studies and clinical trials for all members of the network, including those with hemophilia, those with von Willebrand and other mucocutaneous bleeding disorders, as well as rare bleeding disorders. And it would seem that within this network, one could actually join the registry beginning at birth. And as symptoms developed or risk factors were recognized, these individuals could hop onto clinical prevention trials, clinical intervention and platform trials, or could enroll in a predictive biomarker study or various observational studies, or even in industry post-licensure trials. But the idea is that these were all supported by the HTC network, and one could then hop on and off the registry to participate in these various trials simultaneously. So we also ask, well, what are the research partners that we need to build this infrastructure? And it was very clear. We learned that to assure success and sustain this effort, we have to have partners within the community for engagement, planning, and participation. The HTC network becomes incredibly important because within this network, we are going to engage in research. This would involve not just the physicians, but the staff, the support, and they would need training. We would need a network database with common data elements and patient-reported outcomes. We would also be interested in whether we could do remote visits or decentralized studies. Foundations would be absolutely critical to sustain this research. And trialists would be important for trial design, statistics, epidemiology, clinical trial research networks would be important to involved in doing this. HTRS, FWGBD, supply ideas for modeling and funding, and our IT partners, informatics, big data, electronic medical record are very critical because some of our trials could actually be run within them. And then finally, providing oversight for the entire proposition, the funding, community engagement would be NHF. Now, what are the tools in our toolbox that we either have or need to acquire to conduct research in this community? Well, first, we need a central IRB. We need to have master protocols that allow multiple study arms at the same time and that clearly, quickly, and more efficiently allow trials. We need small trial design and epidemiology expertise. We need both biorepository and a data repository. We need innovative design, decentralized trial capacity, and I'm going to talk about that in a minute. Community partnerships, which are really critical for us to move forward and to understand what the community wants and what we are going to address. We also need to have a toolbox for data collection, data repository, the common data elements, the patient-related outcomes, and basic science and laboratory expertise. So what are the novel designs that we might consider? Well, here I'm showing you in the schematic diagram a decentralized trial design, which, as you can see, goes from really right one-on-one in a clinic to fully virtual all the way on the right, from a research facility to remote locations such as your home. And what the decentralized approach, we took a page right from COVID. You can do remote visits, telemedicine visits, at-home monitoring, home drug delivery. This is less restrictive, decreases the burden, more personalized, and it's really much more real-world setting. And for many of our studies, this might be the way to run them. But we asked ourselves also, well, what is the best approach to a clinical trial? And you know, what we heard from the community was the trials we have are too expensive. They're too inefficient. They take way too long. We heard that to implement our research, we have to be efficient. We have to get these reduced cost and incorporate research right into the hemophilia clinic. Now here, is an example of an adaptive trial. So patients enroll on the left, they're randomized, you have an outcome reported, trial data is updated, and when an arm fails, you notify the patient immediately. That arm stops. The patient then can either go on another arm or other arms are added, and you update and continue to randomize. This is flexible, adaptive. You can have simultaneous evaluation of multiple drugs. It stops, there's no starting and stopping. It is continuous. And it involves the community in the planning, the design, and the enrollment. And it incentivizes many of our partners to also work with us, because early data and phase 4 studies could easily be done here. There would be novel funding and strategies. And we have also recognized that we need to have our physicians come together in the same sandbox. So they have to have some academic recognition with co-author, PI training, and mentorship potential. So the next question that we came up with is, well, what type of model do we need to have this, bring this resource infrastructure and resources into a model? So what we envisioned, we had two models in mind. In this is the HTC network is the coordinating center for, so we envisioned 8 to 10 regional hemophilia networks, and each would enroll and conduct research in their general region. And then we would have an external data coordinating center where all of the very high-tech, innovative design data banks, central IRBs, and informatics might be done by an external data center. But we also thought it would be important to consider model 2. And in this model, what we're doing here is all of those regional networks would be able to not only enroll patients, but where there is expertise, add their expertise in statistics, in design, in IRB, in electronic medical record, as these are able to be done. So this is more of a self-contained model, and you would use only additional members in this model where you have no expertise, where you might send out an RFA or request for that kind of expertise. So what is the governance that we see to promote this network? Well, we think that the HTCs are critical in this network. They would provide a steering committee, and they would be part of a protocol review committee. As protocols are reviewed, evaluated, we would have federal partners who would provide external advisory oversight, and some of our partners, HTRS, AF, and FWGBD, would also provide oversight, and the patient community critical in providing external advisory oversight, and NHF would, of course, provide external advisory oversight as well as fiscal oversight. And then finally, what are we going to do to assure that this network can be sustained to provide the research that we know we can do? Well, it's really critical here that we assure consistent funding streams for support and sustaining this research network. We need partners who are our patient community front and central to this whole effort. HRSA, which has a major role in our HTC network, NHLBI, CDC, charities, foundations, insurers, industry, CTSA, and of course, NHF. And I think really the work that needs to be done is determining how we leverage this important partnership, what each member brings, what each member will actually experience in doing this, and how critical our partners are to our success in this network. And I think I'm going to stop there. Thank you.
Thank you so much, Maggie. We appreciate that. And it was a great, insightful overview. We'll now turn over to Diane to start. Diane, if you'd like to share your screen, feel free. Oh, you're muted, Diane. I'm sorry. Yeah, Diane, I'm sorry. You're still muted. Yep. There you
There
go.
was some background noise and I muted and then I forgot. Sorry.
Oh, no worries. No worries. Thank you.
First of all, welcome everybody, all of you 51 participants out there. This is a great honor to be part of this project, which I think will be a paradigm shift. I think we'll all look back on this effort and say this really changed. Access to care for patients with rare disorders and bleeding disorders. And it's also very innovative and going to change the way we do research for patients with these disorders. It's been a long time coming, but I want to thank NHF. I know all of us who are involved in this effort really want to make a difference and make it happen, not just strategize, but actually implement a lot of the great ideas that are coming out of that. So I will go ahead and give you a brief update for our group, but I know I share the feelings of everybody in our working group that this is such an important thing. And I will pull this up now. Okay, well, we've all gotten fairly better at doing Zoom, so I'll try and be as good as everyone else on this call. It's been excellent. So we're working group 3, and let me just tell you that the focus of our working group has been really drilling down for the ultra rare inherited blood disorders. So much of what was beautifully presented ahead of me by Dr. Ragni applies to this same group. But I think everybody recognizes that the ultra rare disorders, when you put them all together, represent a huge group of patients, and their needs are so far from being met as compared to hemophilia A, B, or von Willebrand's, that we felt that these 3 major areas of focus would help to move forward their access to care for diagnostics, for access to clinical trials, as Maggie just beautifully summarized. And of course, clinical trials of any kind are heavily dependent on data collection, not just for the trial, but as background. And so we spend a lot of time working on that. And the regulatory processes really need to open up for people with rare disorders. And a lot of the restrictions that are there for, studying heart disease and diabetes really are major barriers for getting good clinical trials and access to new therapies. I led the first group, Suchitra and Amy, you can see credited for being the chairs. I must say, though, that speaking as a chair, the body of work in our group for sure should be shared completely. Everybody contributed fully. And that's true, of course, for the clinical data collection research infrastructure group. You can see there's just all stars in each of these subgroups, and we want to give them credit as we go along. Many of you in the audience may recognize either your name or one of your leaders on that list. So what are some of the major questions that we identified after all of our initial meetings for diagnostics, systems biology, and mechanistic science? I'm going to drill down on that a little bit today, being this is just meant to be a 10-minute, 15-minute update. Each of these categories could be addressed within a much longer presentation, and I believe they will be presented shortly to the group as a whole. But before I move on to sort of the diagnostic section, I do want to point out that integrated in with what Dr. Ragni just presented is a lot, which represents a lot of the discussion that we had. But for the ultra rare patients, do treatments exist? Are we going to need to go to specific replacement, which for ultra rare has never been achieved because there just aren't enough patients to make it financially feasible? So maybe we should be focusing more on global treatments that will change the overall coagulation status of a patient, but not in a factor deficient way. You've heard already from everybody else probably the importance of centralized data collection. That's particularly true for the ultra rare because there's so few patients. If we just have little pockets of data on 1 or 2 patients, it's not going to help us. It all needs to be centralized clearly. And I think as part of this process with all the teams that are working on this, we will end up with a good centralized data collection. Right now, of course, Athens has been really great for the HTCs and helping us tie together data. I'm hoping that they will be a big part of our solution. The research infrastructure, which you just heard beautifully presented by Dr. Ragni, as I said, it's going to be really important to get that set up, but will the ultra rare patient be included? And we want to make sure that there's infrastructure for patients with factor 10 deficiency, factor 5 deficiency, things that occur in 1 and 2 to 3 million. I think a very important area that has not been addressed adequately, this is a group being led by Dr. Shapiro, is really how we can, again, return to the FDA and find out how we can better open up the pathways for the rare patient. You know, they're not going to have huge clinical trials for the handful of patients that have, for example, factor 10 deficiency in our country or factor 5 deficiency. So if we use a global agent, you know, something that lowers AT3 levels, for example, in patients, and that is a good therapeutic for many, many patients with factor deficiencies. How do we collect that data? How do we get rapid approval for patients with a rare disorder? So these are going to be talked about at length in future summary sessions, but I'm going to move back to the section that I led and try and give you an example of the sort of discussions that are going on and the innovation that we're hoping that we can bring to the table in the diagnostic area. So this is a good example of what patients with ultra rare disorders experience. Sometimes they're called the Odyssey patient because they're, first of all, primary doesn't know where to send them. They're sent to a hematologist, or many of our adult patients to oncologists, where they're misdiagnosed, or they're referred and referred again, misdiagnosed. And this pattern results in years delay in diagnosis for the ultra rare patient. So we want to change that. That was the pathway to diagnosis was one of the most important things that we felt could be addressed. So starting all the way back with the primary care physician, how does he know what to do, he or she? What screening labs to send, what screening lab, where to go next when the initial screening labs are not diagnostic. And we talked a lot about setting up a national center, both telehealth, Zoom, or call center for physicians to reach out when they have a patient with a bleeding disorder. How do they start the workup? What do they do? You know, NHF has a great site that many folks can go to and say, oh, here's a basic approach that you need to take. The vast majority of physicians don't know about that, don't know how to send it. So we really need, once this is set up, significant effort, I think, needs to be made to establish websites. And on that website, of course, should be here's your local HTC, here's your local HTC diagnostic center, where you can refer a patient for evaluation. Many times our HTCs are left out of network, and again, that really lengthens the time to diagnosis for patients that are on in healthcare centers. I get samples all the time for factor 13 from a physician out in the middle of nowhere, and I say, well, you know, you have an HTC, you know, just 100 you know, miles away. You have local expertise. You don't have to call across the country, you know, to get this input. So communication, really build a strong network that every physician, every provider, nurse practitioner, PA knows how to access, and where to send those patients locally, and where to go to send core diagnostic labs. So that brings us to the issue of, do we need a centralized site or labs? that really know how to do and diagnose rare disorders. And this is very important because I think a lot of people believe that if we just do genomics, that the diagnosis will fall from the sky. Unfortunately, that's not the case. And what we've learned is that sometimes patients have more than one deficiency. Maybe they have multiple factors that are what we call gene modifiers that change the phenotype and so on of the disease. So identifying sites, maybe 3, 4 throughout the country that have both CAP-CLIA recognition as well as basic scientists who can look at that diagnostic picture is going to be really important. But just collecting the data and getting it into a database, as you can see highlighted here under the second bullet point, so that we can link a diagnosis, phenotype, and family history is going to be key. You heard that from Dr. Ragni and many other groups. Strong linkages with the HDCs for referral. At the HDCs, there's still a need to train workforce at the HDC to draw the blood properly, to spin it down properly, to freeze it properly. These are all called pre-analytic factors. If all of that is done well, those samples can then be shipped to one of these national centers for both evaluation workup and genomics at this, hopefully at the same time. And we really need to set this up so that when you're asking a research question, research in the sense that you don't know what the diagnosis is, you need to find the diagnosis, that you don't have to create an IRB approval form for each and every patient. So I think that's a really important infrastructure step that we need to make. If you have a rare patient, you don't know what you have, you want to send them to a research center or a referral center, we shouldn't have to write an IRB research approval every time that needs to be sent. So how do these researchers find the patients? That's the other thing. We have incredible people doing work in fibrinolytic abnormalities. Well, I have a patient, I see that they have a fibrinolytic abnormality just based on the TEG or based on a euglobulin lysis assay, something really simple that might be done in our local lab. Who's doing work in that area? We need to set up a mechanism for matching, sort of a dating site, where patients and researchers can link up, because this is so important for us understanding the underlying pathophysiology of the ultra rare disorder. It'll help us understand basic coagulation if we understand how those defects result in a bleeding or clotting phenotypes. And in order to do this so that you get a clinical report as well as a research report, one of the innovations we're suggesting is to create hybrid labs where there are people who can drill down, do the diagnostic sort of immunoblot, flow, other much more advanced kind of workup, and then turn to the CAP-CLIA certified person and say, okay, we need to generate a report that can be official and will be accepted in the chart. And so these kind of hybrid labs, I think, are really important, and we're hoping to create a national innovative approach for that. It's been very, very challenging because that combination oftentimes is not supported by hospitals or institutions. I think Mayo Clinic is a great example of where you have both researchers and CAP-CLIA certified expertise under the same roof. And that's why people go to Mayo to get their diagnosis done. We need to establish more sites like that where samples can be sent and diagnoses made and then reports generated. And then finally, of course, I mentioned in the beginning, we were all hoping that genomic approaches would answer a lot of questions for our ultra rare patients that have been looking for a diagnosis. Unfortunately, cost is still an issue. The bulk of patients that are in small insurance groups cannot get access to genetic diagnosis. And then when we do whole genome, for example, we get a plethora of variants of unknown significance. in fact, hundreds of them. One of those unknown variants may be diagnostic, but at this time, it's very hard to annotate all of this. So that work still continues, needs to be done. It'll be greatly aided by if we can do family studies, what's called trios, but then that multiplies the, if you do a whole genome on everybody to sort out, oh, that variant's in the person with the bleeding disorder, and the parents don't have that, it helps us to really sort out which variant is the pathologic variant, but then you're multiplying the cost of whole genome by 4, for example, if you have a family of 4. So there's very few genomic companies that will, well, number one, none are really focused on rare disorders, but none of them can really afford to do these kind of trios and family studies that will help us. So the cost is coming down, things are getting better, but we really need to reinforce and strengthen that. ClinVar, which is bringing in the phenotype data and the variants of unknown significance and trying to map them, are doing the best job they can, but their focus is really not on bleeding disorders. We need to really help the NIH and other centers identify that this is very important. And again, only 50 to 60% of unknown bleeding disorders are diagnosed with whole genome because of these challenges. But it's also important to remember that some genetic disorders aren't really a result of a variant or a mutation in factor 7 gene, for example. It could be the gene looks perfectly normal, and the problem is a post-translational change, glycosylation, or an upstream, a major defect where there's no promotion of that particular gene, no translation of that gene. So there are many other aspects that we need to invest in to really understand and diagnose the rare patients. And of course, there's always the acquired patients with antibodies. So these specialized labs need to be able to, lab centers need to be able to diagnose that as well. And I just wanted to throw out a lot of ideas. I know we have patients and a lot of folks out there. There's hope in sight. I think there's hope in sight to shorten the pathway to diagnosis for patients, and also really strong work in our group looking to change regulatory at the FDA and to integrate all of our ultra rare patients into the clinical trials network that Dr. Ragni so beautifully presented initially. So I'll stop there and entertain questions at the end along with the other speakers. Thank you.
Great. Thanks so much, Dr. Nugent. We appreciate that. And we'll turn it over to Dr. Baldwin to get us started. If you can take yourself up. There you go. Great. And it's all yours, Dr. Baldwin.
Hi, everyone. Thank you so much for inviting me to share our work today. Hopefully you can see my screen well. I am so excited to be here as part of this group. I'm an OBGYN, a surgeon and a researcher, and I primarily take care of adolescent girls for menstrual management, but I do the whole lifespan as well. And together with Angela Wyand, we co-chaired our working group, which is called Women, Girls, and Persons Who have have had the potential to menstruate. We had a charge to identify research priorities for this specific population. So unlike looking at a specific bleeding disorder, we are looking at a specific population and identifying research questions that there are gaps for. And Angela wasn't able to be here today, but we created this presentation together. There are many opportunities throughout the lifespan for women and girls and people with potential to menstruate to have bleeding experiences. And so we created a working group that would hopefully hit all these high points as well as all these life transitions with the impact of hormones. In particular, one of the biggest issues with our population is that we are hit with a huge health disparity, both in research and funding for research that has been in place over the years. For example, there are very few publications regarding menstruation compared to semen analysis, just for example. funding for prostate cancer really exceeds funding for studies on uterine cancer. So we want to be able to narrow this gap. This gap is primarily in place as a result of sexism that's been well established, but this impacts not just research, but also assessment of patients, also diagnosis, also referral, also resource availability. So we had our eye on these gaps. Oops. Our working group, we selected a broad representation from physicians, from researchers, from community members, advocates, and this represents hematologists and OBGYNs and physical therapists, among others. So we had representation from trans clinical research. We also had some highlight people from NHF join us. So we were so excited to work together to just put down on paper all of the ideas that we have about gaps in research. And I would say that we were missing here potentially basic science researchers to a large extent, and focused a little bit more on clinical research. We identified through sitting down and having conversations together about research priorities, some basic topic areas. And so these focused research domains, we started with talking about uterine physiology and bleeding, bone and joint health throughout the lifespan, sex and gender lifespan biology, so how hormones affect all sorts of aspects of bleeding assessment, of bleeding management throughout the lifespan, and then pregnancy and postpartum as a huge component. We didn't initially sit down and talk about healthcare delivery for this population, but that became a highlight later on. And we also were consistently talking about patient-related outcomes and quality of life outcomes. And we ended up making that a separate domain as well. But for each of these domains, we talked about mechanism of disease, diagnostics and screening, therapeutics, clinical trials, the quality of life outcomes, advocacy opportunities, and collaborations. So I'm just going to to show you what we ended up settling on as some of our real foundational gaps, the ones that we need to answer before we move on to some of the more nitty-gritty. And these three or four examples are really some basic foundations. So for example, on the left, norms and standards. We really lack an understanding of what are the laboratory norms and standards for all sorts of hematologic indices and outcomes for our population. We lack an understanding of phenotype prevalence throughout the lifespan. So what does a specific bleeding disorder look like for a female at different ages and with different exposures to different hormone levels? We have difficulty with bleeding measurement. So we've created great assessment tools for patient reported bleeding. We've created a really great complex, very expensive tool for measured menstrual blood loss, for example, which the FDA requires in order to do research studies. But what we really lack is a feasible, inexpensive method for quantitation of blood loss, both at the time of birth and at menstruation, to be able to compare interventions. And we really have made some great headway in assessing patient-centered outcomes for our population, but throughout the lifespan, in particular for younger patients and for much older patients, we really have a poor understanding of the impact of bleeding disorder on their lives in particular. So I'm going to just go through some of the more specific topic areas and just demonstrate a smattering of some of the questions that came up. So our process was that we had these individual discussions about each of the domain areas, and we created huge laundry lists of questions. And then we went back and tried to lump the questions into kind of overview topic areas so that we decreased the number we were dealing with. And then we prioritized the questions and ranked them based on how feasible, how much impact they would have, and also on their methodology. So we were using this framework of feasibility, impact, and essentially risk. So how easy it would be to do the study. And so once we got our scores, they tended to sort of hit right in this blue circle area, which is that they were mostly high impact and mostly high feasibility and mostly low risk. And that made it a little hard to see which ones were better than others, because I think that when we were sitting down, we're all thinking about being pragmatic and wanting to have questions that were feasible and low risk. So for example, with sex and gender lifespan biology, the bigger circles, sort of in a not very scientific way, represent what seemed to be most important and foundational, going back to hemostatic levels, reference ranges, pharmacokinetics, and pharmacodynamics, which would impact bleeding disorder phenotypes. What is the impact of genotype on those outcomes? What is the impact of comorbidities such as current COVID infection or something like that on those outcomes? And what happens at different transitions during aging for pubertal and menopausal transitions? And then what is the impact of exogenous or endogenous gonadal steroid hormones on those outcomes? So these questions were generally higher cost and lower feasibility, but with high downstream impact. So that became one of the most foundational ones. For patient-reported outcomes and quality of life, we really think that mental health impact was the most important and foundational outcome that we lack. And that was connected to all of these other outcomes and experiences that are particular for our population, not limited, but particular for us. For example, menstrual bleeding patterns leading to gender identity and sexual health and reproductive choices, symptom correlations between, for example, dysmenorrhea and heavy menstrual bleeding, that impact on healthcare utilization and health behaviors, recreational engagement, and educational and vocational goal attainment, that impact on family and relationships, and even parenting experiences. So these questions were high feasibility, we thought, and moderate to high impact, and really will be very important to follow through on. Pregnancy and postpartum, sorry, clicking my button too quickly. Again, going back to this blood loss quantitation question, I don't have to tell you all that there's a lot of amniotic fluid that comes out at the time of birth that really makes it difficult to measure the blood quantity. And there's a lot of people really working on that quantitative assessment, but it's quite expensive and not disseminated to community hospitals. So we sometimes miss this opportunity to identify that there actually was significant bleeding and find out what to do with that patient later. So this transition between having a hemorrhage at time of birth and then following up with diagnostic testing after that is really not well utilized broadly. And so that quantitation is important for being able to compare interventions like hemorrhage prophylaxis and treatment, workup, prenatal diagnosis, and understanding hemostatic mechanisms. So there are some risk concerns with this kind of study, and some potential for higher cost and lower feasibility, but high downstream impact. Uterine bleeding, very similar topic. We really need to understand how to feasibly compare outcomes of bleeding so that we can compare dosing therapies and have that be acceptable to the FDA as to be able to add indications onto, for example, birth control pills as being approved for use for just heavy menstrual bleeding. And that would improve being able to have access to those medications for some patients. Let's see, higher cost and lower feasibility, again, potential high impact and low risk in this topic area. We spent a fair amount of time talking about bone and joint health, and also made sure that we weren't overlapping with some of the other working groups on this topic, but really just understanding that we don't quite understand the prevalence of subclinical joint bleeds in our population, or the role of steroids, exogenous or endogenous, on joint health and bone density, and the biomechanical differences that are specific based on sex and gender. These were thought to be of uncertain impact, but really high feasibility and low risk. Healthcare delivery questions really were most importantly about screening and referral, and identifying opportunities for training in primary care, and also for developing clinical guidance for example, who should be screened for a bleeding disorder after a hemorrhage at the time of birth. And that would require big interdisciplinary integration and an assessment of comparative models for time to diagnosis. And we weren't sure if healthcare institutions would be excited about these kinds of studies, but we thought they would be high impact. So going back to these foundational research gaps, we think these are the places to start with, to be able to build on for future more nitty-gritty studies that can hopefully bridge this gap in research for our population. We were really excited to work together on this this really novel way of thinking about research priorities. One of the important things that came up was, along the way, we came up with a list of potential collaborators who work in the area of women's health and trans health, and would who already have research networks placed for assessment of contraceptive technologies, of hemorrhage management at birth, for example. And these research networks will be important to connect with, to think about utilizing their skills in these areas. These are just some of the lists of them, such as the Contraceptive Clinical Trials Network or the Maternal Fetal Medicine Units Network. And I will end there.
Great. Thank you, Dr. Baldwin. Appreciate that. We do have several questions that came in, and I'm going to start from the top here. The first one is for Dr. Ragni. Can you explain what platform trials are? I understand clinical trials, but I'm not familiar with platform trials.
Well, thank you for that question. I think it's a very interesting topic. It is quite complex, but in essence, a platform trial utilizes a number of approaches that make clinical trials efficient. So they will take for example, a registry group and use them as the controls. They will run multiple drugs at the same time. And the efficiency there is that with one drug, as soon as it fails, yet another drug will come up and take its place and be part of the assessment without having to restart and redo another trial. That's really critical in terms of speed, in terms of cost, in terms of efficiency. There are also a number of approaches to reduce the number of patients on a particular arm by implementing some of the data that are known with that particular drug, so that you can reduce sample size, which is critical in a rare disease. I've had the chance to work with a wonderful group of experts, trialists, the Berry consultants. In fact, they helped me to design one of my trials in which we did just what I'm telling you. Part of the numbers were from what we already know in the literature. The rest we are enrolling. You can use controls from registries. And that's another underscore that putting a trial within a registry is something that COVID did. That is the incredibly knowledgeable and really brilliant experts who ran some of the clinical trials in COVID, such as the REMAP trial run by one of the investigators at my institution, in which they just put it right in the electronic medical record. Others used registries. The point is, if the data is already being collected, just then use that data, obviously with the approval, with all your regulatory needed questions answered, but to then immediately use that to select which, if you have a patient, you can enroll them based on, you can actually randomize right within that electronic medical record. I think a lot more of this will happen. I think it's becoming much more common to be done. And in the same way, big data is being used in the exact same way. Can we identify patients who have von Willebrand disease without doing all this craziness, but actually do a bleeding score using big data in the electronic medical record, find out who doesn't, who has these problems, and who might potentially be eligible for a study or what have you, and certainly be seen by a hemophilia center. But thanks for that question. I don't know if I answered it.
I think so. I'm not a medical professional, but I think it sounded pretty good. I will move forward here with the next question. This is for Dr. Nugent. And this comes across and says, for ultra rares, could there be something similar to the oncology tumor board model, but not on a national basis, that would offer recommendations or referrals and anyone can join in and participate with? This could even be virtual.
Absolutely. And I'm not sure who asked that question, but thank you. It's a great question. And we do something very similar to that now, which is a resource that we're talking about using, and that's called the Echo Call. This is a way to sort of teleconference together. We are very happy and using it frequently in the sickle cell network, not only for telementoring, but for exactly as this person who asked the question is suggesting, and that is that any number of people can join in. A case is presented that presents usually a particular clinical challenge or is representative of a new technology or a new technique that we would be using. But in the case of the ultra rare, or to parallel what's done with COG or the other cancer groups, a case would be presented in a de-identified manner, and people could, of course, log in. They could comment, and another nice thing about it is that you can collect the names. You can reach out to people again afterwards. And this Echo technology, which was developed at the University of New Mexico in Albuquerque by a clinical researcher who wanted to, probably Maggie may know him, wanted to get more data out about Hep C, and to reach out to the prisons and to reach out to all these other entities that weren't previously connected with medical centers. And so they created this Echo technology. So it's a very safe, secure line of communication that can be done among groups. And now it's being applied by many, many people. So the Echo Call technology or something similar to it is a great opportunity for cases to be presented at discussions and so on. And similarly, this is being done for the rare disorders in general. So great question, and absolutely something that we hope to accomplish.
Great. Thanks, Dr. Nugent. The next question comes in for Dr. Baldwin, and it says, thinking of what Dr. Nugent just spoke about with the Echo Call, would something like that work for collaboration with the OBGYNs and IBD specialized providers? And how do you publicize these types of programs so you can develop it?
Great topic. Yeah, the volume is so vastly different in women's healthcare compared to ultra rare disorders, for example. And so this kind of doesn't exactly match up as easily as you'd want. I think that the model that is emerging that seems to be very effective is these interdisciplinary clinics between hematology and gynecology in particular. Nationally, we've seen a huge increase in these combined clinics, and interdisciplinary clinics in general at academic centers, I think, are increasing overall. Just the knowledge that I gain from sitting next to someone who can actually read a von Willebrand panel and understand it better than I can, and I'm learning, but that is really so helpful, and doing it in real time with the patient, with both providers together, is really helpful. Now, how do we move that from academic sites to community sites and to, even just elsewhere in our cities? I think having webinars and meetings where we present together has been helpful. At our local site, we go on this, what we call our road show. We do grand rounds together at several different community sites, and we have like 2 presentations. It's not very hard work for us, but even just presenting, like, what is the initial workup that you should do if you suspect that a teenager has a bleeding disorder just from her periods, that by itself has generated a huge amount of confidence in our community partners, such that they usually have tried the basic things first before they refer them on, and done the basic panel workup. So I would probably recommend a model more of local education, rather than webinar meetings that are, all, you have to make it to one certain meeting to learn the thing, but just more of dissemination of real basic education.
Great. Thanks, Dr. Baldwin. Appreciate that. And I think we've got time for one more, and I'd like to go through the group for this. I think it's a good question that really applies to can apply to everyone. But did the groups discuss how to find the undiagnosed? What groups of providers need to be included in this outside of the HTCs? Probably a good question for everyone, I would think. And Dr. Ragni, if we could start with you.
Well, we did not specifically address diagnosis or case finding, but as I was mentioning, when we had our discussion about big data and machine learning, we worked with experts from Carnegie Mellon University right down the street from us, who are actually working with us on several research projects. But one of the questions that they asked was, we asked of them, can we use the medical record to try to identify patients who have von Willebrand disease, who are out there in the community that we only meet when they're in extremis? That is, when they've had surgery and no one even knew they had the disease, or someone said, just give them a dose of DDAVP, which was not anywhere near enough. So can we actually diagnose all those who are affected and bring them in, not just to our research community, which is what we're talking about here, but also within our own HTC network? And actually, that also underscores the beauty of having the research network within the HTC network. It is just a hand in glove approach, because once we know who is affected, we then immediately involve them in registries and in trials and biopredictor markers and all sorts of things. But I think machine learning will play a bigger and bigger role in our getting this to happen, because these patients have delay in diagnosis of almost 20 years from their first bleeding symptom, which is absurd and which should not happen. And our bleeding disorder patients should not be bleeding without already being known and having appropriate treatment available. Thank you.
Thanks, Dr. Ragni. And Dr. Nugent, we'll move to you.
Okay, this is a huge topic for us. And I must say that besides the sort of EMR, electronic medical record, and the massive AI that is beginning to come on, I have an EMR that when a ICD-910 or 10 code comes up, there's actually something that pops up and says, have you considered this diagnosis? And, the more that we can do that and embed that into the electronic medical record, the more often a physician or provider And when I say provider, you know, many of our providers now are nurse practitioners and physician's assistants, and getting the information out to them, not just MDs, but nurse practitioners, PAs, and have that embedded in our electronic systems, so that if bleeding, just the term bleeding comes up in a diagnosis, and something can pop up and say, have you considered this? And, you know, here's the website. As a national agenda, it would be phenomenal, you know, to identify. And, you know, of course, most of the time, maybe nothing, maybe a single event, but I can tell you 1 out of 500,000 times it's going to be a factor 13 deficiency. And so I think, you know, it's for the ultra rare, that's what it takes, because it just doesn't happen that much. But then the other piece is, and I'd like to credit Dr. Ruthie up at Mayo Clinic, who comes up with the term of the pathway from primary physician to diagnosis. I mean, we really need to get out there either with newborn screening, education at the very first level, but throughout the continuum of providers, because it's not just a neonatal problem, not just a pediatric, not just a young adult, not just an OBGYN, not just, you know, it's something that this bleeding can occur throughout the lifetime. And we need to make sure that people that interface with that patient have that second thought. And so whether we trigger it electronically or through AI and our massive ability, I think honestly that for the ultra rare patient, what you just heard Maggie describe and so on is really true. And I just want to say to Maureen, sitting next to the OBGYN person when we go over the hormone results in the FSH and LH is as miraculous to me as your feeling about the von Willebrand. So I'm going to boot this over to you, and thank you everybody for your great questions.
Well, I'll just mention a couple of ideas that came up about finding patients. You know, we have a poor pathway for postpartum hemorrhage to workup. We have a poor pathway for menstrual hemorrhage in the emergency room to workup. Those are two hot spots that I think we can improve on. Educating emergency physicians, you know, potentially with, I love your idea, Diane, about a pop-up in the EMR, you know, that just automatically generates a consult. Or, you know, not everybody has a PCP. They go to the emergency room with their menstrual hemorrhage, right. They get their pack of pills, and then they go home and don't follow up. Those are two big areas, but I would love to see us, you know, take that even a step further. And if we have a postpartum hemorrhage that's otherwise unexplained, we start working up the newborn, you know, so obstetrics to pediatrics transition as well as could be really helpful. So I will just end with that, but I love all the idea generation. This is so fun.
Bravo.
Thanks to all of you for taking the time to join us this afternoon. We truly appreciate your time and your expertise, and thanks for all you've done through the State of the Science here as well too. I know that's takes a lot of time, and there's a lot of coordination and a lot of thought that goes into that. So we truly appreciate that. Please note that this recorded webinar will be available on Friday, August 6th at hemophilia.org under the events tab with all of our other archived webinars. Also available in the events tab is our upcoming schedule of our weekly Wednesday webinars. Thank you, Dr. Ragni, Dr. Baldwin, Dr. Nugent again for joining us and for all you've done for NHF. Have a wonderful week.
Great, thank you. It was great fun.